Good afternoon, everybody. So after the long conference, we'll come to the last bit of it. So I'm trying to talk to you about something called the cost line, which may be a couple of years. It may take a couple of years for it to become absolutely popular. So maybe you can take this as a pre-advance order of what is to come in a few years to come. So basically, what we mean by the cost line is the cone outer segment tips. Since we got this presentation done and got the IC, a lot has changed in fact on the cost line, which I'll come to you. So this is basically what we're trying to see, that is the retinal histology. And when we started, images looked like this. They got better and better, and finally we have images that look as good as this. So the nature of the talk has changed in a while, that we're not only looking at the cost line, we have divided the outer retina into three particular segments. One is the ELM, the second is the eye cell or the inner segment ellipsoids, the third is the cost or the cone outer segment tips. So the whole outer retina is now construed to be three particular layers, which are gaining a lot of significance in disease. So just going through a particular slide, this shows the layers. The retina is divided into four hyperreflective bands, in which the first is the ELM, the second, which was called the ISOS or the PIL, the photoreceptor integrity layer, and now it is being called the ellipsoids, and the third is called the COST, the cone outer segment tip layer, and the last line is the RP, which is actually again divided into two, that is the RP and the Brooks RP. So an anatomically correct model which is mentioned is the external limiting membrane, also called the junction complexes, the eye cell level or the inner segment ellipsoids, the interdigitation zone or the cost line, also called the cell-cell contact layer, and the RP Brooks complex. Again, we were talking about the four hyperreflective bands. Now instead of four, we're considering as five bands. The RP is divided into two now. Another picture showing those, you see you have the ELM, the eye cell, the cost, and the RP Brooks complex. So the identification of the layers start with the ELM, which is not very difficult to identify. So what contributes to the ELM is the complex, is the connections between the the molar cell and the inner segments of the photoreceptors. So this particular eye cell level, the significance is that it has nutritional support and also structural support to the rest of the layers of the retina, the outer retina. The ellipsoid zone, sometimes also called the ICE or the eye cell band, is the inner segment ellipsoid. It's contributed because of the more mitochondria seen in the ellipsoid of the inner segment, and it forms a particular band, and it is thought to be due to the cone cells, the cone ellipsoids. Now the outer segment tips is called the cost line, also called the Verheves membrane, the interdigitation zone, or also called the cell contact cylinder, because it's the area of contact between the RP outer segment, the photoreceptors, and the microvilli of the RP. So again, because the cone segments are shorter, as Dr. Preeti had shown in our picture, and they don't exactly entwine, they form a more hyperreflective band which is above the RP. So now we've come to the identification. We'll think of the clinical significance, and because there are not a lot of studies, I've picked out 5 studies which kind of characterize why we should be looking at these layers. The first is this study, as the importance of the cost tip as a prognostic factor in ERM surgery. Okay, so these are some of the conclusions of the study. Is that after ERM surgery, there is a temporary disruption of the cost line. Okay, if it was not already disrupted in the first month, and then over 6 months, the cost line reappears, which is very interesting. So when you look at the long time, you can think that the cone outer segment takes about 5 months to regenerate. So that is what corresponds to your data from this study, that after a disruption it takes about 5 to 6 months to come back. And the early postoperative status of the coast line corresponded to the visual acuity, and essentially it has become a useful prognostic factor along with the ISOS junction to see whether the patient gains vision after ERM surgery. So another interesting fact is that the eye cell, the ellipsoid zone, and the presence of ELM. Patients who had development of the inner segments ellipsoid and the cost all had intact ELMs, which means that the external limiting membrane or the molar cells had to be intact for the regeneration of the other elements, the ellipsoid and the photoreceptors to regenerate, which is again a good prognostic feature. If you had an intact ELM after macular hole surgery or ERM surgery, you could be sure that your cost would develop over time. This is an important concept that is coming. It's called hierarchy of damage. When the damage is minimal, you would have a cost disruption. When the damage increases, you would lose the ellipsoid. And when the damage goes beyond the photoreceptor layer, you would lose the ELM. So in conditions like macular holes and also non-macular holes, in conditions like ERMs and subtle outer retinal maculopathies and all those things, you would have subtle damage, and the damage would be limited to the cost and the ISOS. But when the damage increases, like diseases like AMD, that is when the ELM also gets involved. So what we're saying is that the loss of the ISOS, or what we call the ICL now, it reflects the integrity of the photoreceptors, and ELM damage shows a damage which is proceeding towards the inner retina more and more. The second study was regarding the macular hole surgery and the presence of the coast line. So this is an example of an intact coast line. You see it in its entirety, and this is called a fragmented coast line, and this is where the coast line is absolutely lost in certain areas. In this particular study, it said two things. First, the inner segment, the eye cell developed first and the ELM developed first before the coast line developed. And all patients who had better vision had an intact coast line. So that is the importance, the visual prognosis of identifying a coast line after a macular hole or ERM surgery. And why does the coast line develop later? I just told you this, because the outer segment, the disc replenishment takes a long time. It takes up to 6 months, while it takes a very shorter time for the rods to replenish. So after the macular hole surgery, there are some people who have a disrupted coast line. It's mentioned due to these particular reasons. It could be an artifact, it could be cellular displacement. The foveal cells could be displaced towards the side by gliotic tissue. It could be an inflammatory damage, or it could be due to surgical misalignment. So I'm just going through these slides, and what we're seeing here is a sequence of closure of some holes. This is what we see usually, the inner segments closing, then you have a small defect in the outer segment. Here you see the reproliferation of some of the layers, and after 6 months you can see that the coast line is, the eye cell is getting better and the coast line is repopulating towards the center. Another study which was indicative of the importance of the coast line was how it developed after PDT treatment for CSR. So again, you have a picture of intact, a disrupted, and a totally a coast line which is totally gone. Again, the white on black, so the black on white is an excellent method of identifying the coast line in some of the machines rather than the regular black on white. So this is a patient who had a CSR treated with reduced fluence, and over 6 months there is an intactness, the picture is not too great, of the coast line recurrence after development after 6 months. And this is a patient when there is a loss of the eye cell and the coast line after PDT, and this was indicative of the prognosis. It took up to 12 months for patients, that is 11 out of 13 eyes for PDT, to develop the coast line. So it's a slow growing process, and patients can have development of visual acuity and the coast line even up to 12 months after PDT. And in the group, they showed that the retinal sensitivity using microperimetry was highest in the group which had an intact eye cell and which had an intact coast line. This is another interesting paper which showed that people may have intact coast lines, but in cone dystrophies, the intensity of the coast line measured is less. This is another journal that came in the Korean Journal of Ophthalmology, in which in cone dystrophies, people were divided into 4 basic categories. One based on the involvement of the eye cell layer and based on the involvement of the EL. This is just an example of probably how we could have a classification of the eye cell and the cost and the ELM in the future. And as I said, there's a hierarchy of damage. First you get the eye cell damage, then you get the cost, then the eye cell, and later you get the ELM damage in an increasing. But whatever happens, in a patient who has got the loss of the eye cell, there was always damage to the cost layer or the cell cylinder layer. When we measure the cost, how sure are we that we're not measuring an artifact? That also becomes an important part of the measurement of the cost line. So what it said that the absent cost line was seen in 4 to 5% of normalized. That means in 94 to 95% of normalized, we could identify the cost line. And this is a graph showing the table showing the horizontal and vertical scans. But what it said is that a fragmented coastline can be considered an artifact if there is a hyperreflectivity at the forewheel pit, which is an important thing. That means an intact forewheel coastline is normal or without artifacts in 95 to 96, and a fragmented coastline can be considered normal if you find a pit hyperreflectivity, which is this. On an OCT, if you find a hyperreflectivity at this particular point, you can look at the shadowing effect behind it. You will see a decrease in the ELM, the ISOs, and the coastline, and this can be considered to be a normal coastline, like an artifactual damage. Okay. So, what are the lessons learned? There could be artifacts while looking at the coastline. One, the visual acuity corresponds to the coast recovery. I would like to stress the point recovery. There may not be a great point looking at the coastline 1 month after surgery or a couple of weeks after surgery. The recovery could be delayed. It happens in eyes with intact eye cell and ELM, which means the supporting elements have to be intact for the rest of the photoreceptor outer segments to develop over time. There is decreased signal intensity when there is cone disease specifically. There is a hierarchy of damage. So these could be the concepts that we take away from these 5 or 6 studies, and with the evolving evidence, it seems that the coastline is getting more and more important. These are some of the pictures that we have collected, and you can see this. First rule, you should never interpret the 4 bands in the presence of edema. The presence of edema causes immense shadowing in different areas, so it is not advisable to interpret the presence of the 4 bands, which makes it not so useful in the presence of active edema in AMD, active edema in DME, but useful as a prognostic feature when the disease is treated. This is a patient with a CSR where you see the ELM properly, you see the eye cell layer, but suddenly you don't see the presence of the coast outer segment tips. It artificially looks like a coast detachment, but it's not. This is a layer of fibrin that is bridging and lining the underneath surface of the photoreceptors. This is a patient who had an ERM with good visual acuity. You can see what is happening. That is adequate. Previously, you would just look at this. Okay, this is adequate thickness. It's good. But if you look at it carefully, you see all the 4 intact layers. You see the ELM, the eye cell, the coast, and the RP intact. So this is congruent with good visual acuity. This is another patient who has focal traction, and if you look right underneath the areas of the traction, there is a loss of the coast layer. So, as I said, the hierarchy of damage. When you have a minimal damage to the retina, you could see an initial loss of the coastline being affected first. Macular holes. We could be looking at prognosis of macular holes by measuring the ILM and the eye cell up the whole layer. So if it is intact and it is pretty much in a good layer, you can imagine that when these come and attach, you have this scaffolding for the rest of the photoreceptor development happening. This is a post-hole management of a hole where you see the ELM has proliferated first and you have a punched out defect, and this is a hole that we can observe for the future to see whether the rest of the layers are evolving. This is a patient post-surgery who had late closure of a hole by himself. It was open after surgery, that is this picture, and as time went by, the hole started closing by itself. And what you see very nicely is that with each picture, you can see the ELM getting more and more organized. The eye cell, though there is a gap here, the eye cell is getting organized. And this is what happened by itself without a resurgery. Your top layer is intact, your inner retinal layers are intact, and you have kind of a creeping of the outer retinal layers towards the center, trying to close the gap. So, in different types of macular hole closures, probably this would be important. You have a total disorganization here. You've got creeping which is coming to the base of the hole here. This is a case of an inverted ILM flap technique where we put ILM inside the hole. Maybe that is preventing the layers from formulating well in this particular patient. This is another patient that we don't know whether it is a disease or an artifact. You have 2 hyperreflective spots in the ELM, and exactly underneath those you have a back scattering happening. So we have a lot to learn about the coastline, but at least as an introduction, if I have created some interest about this, and probably we would be looking at these lines more and more, because we probably sorted quite a lot of the rest of the OCT already. Thank you.